of non-alcoholic fatty liver disease with Dr. Allison Sharp. Dr. Allison Sharp is a gastroenterologist with Norton Gastroenterology Consultants of Louisville. Dr. Sharp received her medical degree from Lake Area College of Osteopathic Medicine. She completed her internal medicine residency at the University of Louisville and gastroenterology fellowship at East Tennessee State University. She is a huge college sports fan. She loves basketball and football. She also enjoys traveling and trying new restaurants in Louisville. Better get in there before 5 o'clock today, Allison. So without further ado, we'll move on to the update and management of non-alcoholic fatty liver disease.
Hey, I'm going to start off by apologizing. When I did my Zoom test this week, everything worked well. And now I have a second monitor installed, and so my presentation may not be showing up correctly. But I am trying to get into presentation mode and nothing is happening. While I'm trying to get this to work, so I have been with the Norton Gastroenterology Group for a little over a year now, and primarily see inpatients or only see inpatients at Norton Women and Children's and Brownsboro, and my clinic is located near Suburban, so happy to see any patients. And fatty liver is a consult I love getting because there is a lot of interaction with the patient and there are a lot of things that really, we can't just throw a medicine at it. It's a lot of working together and counseling and motivating a patient to make lifestyle changes. So I'm not sure if this is coming across.
Allison, we can try and share our screen from here.
Okay. Okay. So really the objectives today are kind of to discuss epidemiology, to discuss natural history and outcomes of fatty liver disease, to talk a little bit about the candidate score and modalities for screening, to discuss effectiveness of lifestyle modifications, and then review the available and the potential upcoming pharmacological options. So when you hear there's a lot of different nomenclature, and basically, and sometimes even in gastroenterology, we can use terms interchangeably that don't actually mean the same thing. And so when we talk about NAFLD or non-alcoholic fatty liver disease, that is just referring to the spectrum. So anything from basic non-alcoholic fatty liver to steatohepatitis to NASH cirrhosis. So NAFLD or NAFLD is that entire spectrum of disorders. So when we talk about NAFLD or non-alcoholic fatty liver, what we're talking about is fat accumulation in the liver with no histologic evidence of any type of hepatocellular injury. And this is in contrast to non-alcoholic steatohepatitis or NASH, where you have fat accumulation in the liver that results in inflammation and damage to hepatocytes. Specifically, we'll talk about ballooning degeneration, which can occur with or without fibrosis. So how do we actually define any of these diseases? So, it's not practical to do a liver biopsy on every patient. So when we talk about this, we really mean there's some type of imaging or histologic evidence of fat in the liver. Generally, we've got an ultrasound or a CT scan that shows fatty liver. And then it means we've excluded secondary causes of fat accumulation, the most common of which is obviously significant alcohol use. Another common one that we all tend to forget, and I think you would even find patients who have seen a gastroenterologist who have the classic picture of fatty liver, they're obese, have type 2 diabetes, we chalk everything up to fatty liver, but hepatitis C is a very common cause of fat accumulation in the liver as well. So very important to screen these patients as well. Then the things that probably none of us will see as often are, TPN use, Wilson's disease, medications. We worry about all medications with the liver, but specifically fat accumulation occurs secondary to amiodarone, methotrexate, tamoxifen, steroids, valproate, and the antiretroviral medications. A few of the ones that we're nervous about seeing because pregnant women can have some scary liver findings are acute fatty liver, pregnant syndrome, and then even more rare, the inborn errors of metabolism. So I like this slide just because it kind of reiterates to me along this entire progression, most of the stages are reversible. So looking at the healthy liver, in the hepatocytes, it is normal to have these small droplets of fat. But here we've got a healthy looking nucleus. The cells are pretty uniform. When we get to, NAFLD or NAFLD fatty liver, this is a reversible change, but now we start to see where large droplets of fat have accumulated into the cells, that the cells get bigger and bloated, the nucleus gets displaced within the cell. And then the next step, moving on to NASH, you start to see, the changes of chronic inflammation there. So collagen fibers will deposit, the hepatocytes are inflamed and start to die. But even to this point, that is still a reversible change inside the liver. With lifestyle changes, we can get regression back to these other stages and even potentially back to healthy liver tissue. And finally, when we're looking at the cirrhotic appearing liver, we've got scar tissue, we've got dead cells there, and this is where we've reached kind of the point of no return and the changes are irreversible. So this next slide, again, we'll talk a little more about all of these things with the risk factors, but again, just kind of a visual looking at kind of the progression. So you've got this entire spectrum of NAFLD, and with just like the general fatty liver, about a 25% risk of progression to NASH. And then over time, each stage, there is, more and more risk of progression the farther down that you go. Next. So then this is nothing new, for you all. I'm sure this is one of the most common things that you're seeing frequently in practice. And so this is not surprising at all, but this is now the most common chronic liver condition in the US. We really don't have great data, but it's estimated that at least 25% of US adults have NAFLD, and I would suspect that number is even greater in Kentucky. And among these patients, approximately 20% of those have NASH. So about 5% of US adults at this time are estimated to have NASH. Again, I think most of us would agree that's probably an underestimation. The majority of the NAFLD-related disease does have the metabolic comorbidity, so obesity, type 2 diabetes, dyslipidemia. There have been studies that suggest that 1/3 to 2/3 of diabetic patients have NAFLD, but there is this subset, and this is just important to remember because sometimes you get these patients where it just doesn't add up. They're thin. Why, they've got a normal BMI. Why do they have this? But approximately 7% of the NAFLD cases in the US may be lean NAFLD, meaning that the patient has a BMI of less than 25. Just a few more things about epidemiology. So it is more common and there is a higher risk of progression to NASH among Hispanic populations. Then on the flip side of that, African Americans, despite having higher levels of insulin resistance, higher triglycerides, lower HDL levels, there's actually a lower prevalence of NAFLD. We think this is potentially due to the fact that there may be less visceral fat, and there's some genetic variations that seem to make these risk factors change. And then finally, this is something I've definitely noticed in clinical practice recently. While we don't have a lot of great data for East Asian populations, it does seem that metabolic disorders appear at a lower BMI at a younger age. And with even lower risk factors, younger ages, et cetera, you're more likely to see a higher degree of inflammation on biopsy. So again, I'm a visual person. I like the pictures. So what we know as far as established risk factors, kind of the no-brainers: obesity, type 2 diabetes, hypertriglyceridemia, metabolic syndromes. But what we're starting to realize is that several of these suspected risk factors are emerging. We think that hypothyroidism, sleep apnea, polycystic ovarian syndrome, rapid weight loss, excess fructose consumption, and a couple genetic markers are probably risk factors for the disease as well. This one is not an exciting slide, but just another visualization of all the things that I like to eat are the things that put me at risk for fatty liver down the road. So really kind of our Western diet, our processed diet is putting us all at risk, to develop these hepatic issues. And really the point of this, and I'll talk about it again in a later slide, is we don't have a ton of great data behind these are the very specific dietary modifications you need to take that we know are best. But one thing that research is showing is a Mediterranean diet has been shown to result in significant improvements in liver histology, even if there is no weight loss associated with that. So just something to remember. But other than that, really kind of the big no-brainers: increase in fruits and vegetables, decrease in processed foods and red meats. So despite all of the scary things that can go along with decompensated liver disease, the most common cause of death in patients with NAFLD is cardiovascular disease still. When looking at different prognostic features, the most important histologic feature that is associated with long-term mortality is, of course, fibrosis. Something that has really changed over the past few decades. Now, NAFLD is the third most common cause of hepatocellular carcinoma. And something that's a little scary to me, there was a study of VA patients, and around 13% of the patients there in this study with HCC did not have cirrhosis. And there were multiple other risk factors identified, but NAFLD was independently associated with HCC in the absence of cirrhosis. It's not entirely clear what to do with this information, as it's not recommended that we screen all of our patients with fatty liver for cirrhosis, but just something to be aware of. And currently, this is the second most common indication for liver transplant. Among the patients, so once we know someone has NAFLD, they have a 20 to 30% risk of progression to NASH. From there, there's a 20 to 30% risk of progression to advanced fibrosis. And then from there, a 20 to 30% risk of progression to frank NASH cirrhosis. And really, there is a lot of variability. The majority of the time we see this progression happen over the span of a decade or more, but it can be seen as rapidly as 2 years in between these different stages. So who to screen? This is a good question. I don't have a great answer, but recent cost analysis suggests that screening everyone with diabetes is not cost effective, largely due to the fact that once we have identified someone as having NAFLD, we don't really have a lot of great options. It's not like we know if we give them this medication or put them in this program that we're going to definitely get everybody back to normal healthy tissue. So we really don't know what to do with everyone once we've made a diagnosis, and that's the real reason why they're not advocating for screening for everyone. The liver function tests are often normal, so they're an insufficient screening test, which can be frustrating. And then imaging is definitely more sensitive than serologic testing, but still we don't really know, who are the best people to screen with ultrasound and elastography. So the expert opinion has been vigilance, but not screening for chronic liver disease in patients with type 2 diabetes. What does that mean? What do we do with that? I don't know. So, this is one that always kind of is bothersome to me as a consultant. Sometimes I feel like I overorder tests, but when we establish this diagnosis of NAFLD, it really is important to rule out any coexisting conditions. And, hemochromatosis, autoimmune liver disease, Wilson's, chronic viral hepatitis, alpha-1 antitrypsin, and drug-induced liver injury. So when we order this battery of tests, it really is important, because if we have one of those, then sometimes it is easier to find a place for better intervention. I will also mention the serologic interpretation of this workup can be extremely frustrating. You've ordered this test and then it comes back mildly positive. What do you do with that? Because it is extremely common that patients with any type of underlying liver disease, but particularly NAFLD, have mildly elevated ferritin. So really the next step with that is to check an iron saturation. And if it's greater than 50%, they probably need a liver biopsy. But if the iron saturation is pretty normal, it's just something to keep an eye on, but nothing that really makes us that concerned for hemochromatosis. And low levels of the autoantibodies are extremely common. I didn't put this on the slide because I couldn't find a great reference, but I've seen in some of the ACG and AGA presentations that they're estimated up to 30 to 35% could potentially have low levels of anti-smooth muscle antibody and ANA positivity. So this, again, this is kind of helpful as a visual, but I think a few things about this are problematic. But really kind of the key point for this slide is that if you do find someone with fatty liver on imaging and they do have abnormal liver function tests, then really, you want to go down the pathway of looking, do they have the metabolic risk factors, and then checking for alternative sources of both of these things, particularly asking about alcohol, looking at their medication list, and screening for hepatitis C. And then if all of those things seem to point you in the direction of fatty liver, then looking at some of the slides we're going to talk about next for different scoring systems and imaging. So the non-invasive testing, so we basically have 3 different subtypes. So you've got the clinical decision aids. These are different scoring systems that you can find on the MedCalc applications. Then the serum biomarkers, really what we have mostly available to us at this time is fibrosis. And then imaging, specifically, there are all these different advanced imaging, but specifically what we're going to be talking about is elastography or fibroscan. I will say one of the major benefits to these non-invasive testing modalities, in addition to lower cost and risk than biopsy, which is not a perfect test by any means, is the ability to repeat these tests over time and with interventions to monitor progress. So looking at the clinical decision aids, so the ones that we really use would be the NAFLD fibrosis score, which takes into account several different factors you can see here: age, BMI, your transaminases, platelet count, albumin, and then the FIB-4 index, which looks at platelet count, age, AST, and ALT. And basically both of these scores have cutoffs that will tell you whether advanced fibrosis is unlikely or whether advanced fibrosis is likely, which may change your clinical decision making and kind of guide you in whether or not this patient needs further evaluation or further imaging. So next are the serum biomarkers. So again, specifically, there are 2 FibroSure tests. These are the serologic panels. There's a NASH FibroSure, and then there's also a hepatitis C FibroSure. So it uses 10 different biochemicals in addition to age, weight, gender, height, to kind of provide some guides on fibrosis staging and inflammation grading. As a general rule, this is just something to keep in mind. If you have an ALT that is greater than 622, number one, you may have something going on other than NAFLD, but that can really throw off these numbers. And then if your bilirubin is greater than 1.8 or your GGT is low, that can affect the sensitivity and specificity of these lab tests. And next, we'll talk about imaging. So really, again, what we have available right now is FibroScan, or transient elastography, which basically uses sound waves to measure stiffness of the liver and gives us a graded analysis on the degree of steatosis and fibrosis. Unfortunately, this is affected by obesity, which is tough because most of the patients that we're sending for this, do have some degree of central obesity. Can also be affected by ascites. So if you've got a patient who's got fluoride volume overload with 10 societies, now is not the right time to get the FibroScan. Elevated CBP as well. So MR elastography shows a lot of great promise. It's superior to FibroScan to identify, advanced fibrosis. The problem with that is it's just not readily available. Even at academic centers, it's generally restricted to use within clinical trials, but that may be something coming down the pipeline later on. And then this slide is just to show when we are kind of interpreting FibroScan, it all is different depending on the cause of the underlying disease. So these cutoffs that we use for fibrosis staging are based on the underlying disease process. When to biopsy, we don't do a whole lot of biopsy anymore, even though it's not a terribly unsafe procedure, there's still risk, of course, and the expense. And honestly, we don't need it most of the time. When thinking about when to biopsy, the bottom line is it going to change our management? If you have somebody with NAFLD who has, a really low titer of an autoimmune antibody, then, even if it were an autoimmune process, it wouldn't warrant treatment at that time. So that's a time we just kind of watch. Now, if someone has AST and ALT that are in the 400s, 500s, they have these autoantibodies that are detectable, then sometimes it would change the management. And those are the times that it's really more important to biopsy. So next, now we've identified these patients, what do we do now? So this is everyone's favorite thing to hear. You can, but I really do stress to patients, diet, exercise, weight loss, it really is the mainstay of treatment for fatty liver. And, even the limited medications that we have are not a substitute for these things. So we know that loss of 5% body weight is associated with an improvement of fat in the liver. Up to 7% body weight loss is associated with an improvement in inflammation. And then loss of 10% of weight is associated with actual improvement in like portal inflammation and early fibrosis. And really, we found that kind of the sweet spot is that a daily reduction of about 500 to 1,000 calories a day and moderate intensity exercise is our best likelihood at sustained weight loss and improvement in liver numbers and histology. And again, with diet, Mediterranean diet has been shown to have beneficial effects, even if it's isocaloric and even if a patient does not lose weight. And I really stress to people, this has been shown to be superior to high fat, low carb diet. I think we're all guilty of it. It's easy to fall into a diet fad where you see results quickly. And I know keto has been that thing for a lot of patients. And just saying that, number one, it hasn't been shown to have beneficial effects on the liver. And number two, for most of us, it's not a sustainable thing. And so really kind of making small changes that may not show a ton of results up front is going to be the best thing. There's also some data that shows that exercise alone can prevent or reduce steatosis, but it's unclear how much it's going to affect inflammatory changes and advanced fibrotic changes. As far as alcohol goes, the bottom line is we don't really know what amount of alcohol is safe for consumption. If you look at the AASLD guidelines, they kind of leave it as heavy consumption should be avoided, which for men is more than 14 drinks in a week, for women is more than 7 drinks in a week. There have been a few cross-sectional studies showing some possible benefit to mild alcohol consumption, which is less than a drink per day. But what I generally tell patients is, you don't have to be a teetotaler if you have a glass of wine generally on Thanksgiving Day with your family or at Christmas, or, every once in a while with dinner, you want to have a cocktail. That's not going to throw you over into liver failure, but drinking on a daily basis is not a good idea, probably even if it's just one drink. Just very briefly, what do we have as far as pharmacologic treatment? Vitamin E is the one that has the most data, the most studies behind it. We think that its antioxidant properties mitigate the oxidative stress on the liver cells, but the trials of vitamin E were underpowered, and they're a little bit difficult to interpret because there were differences in dosing and formulation of vitamin E. But it does appear that there has been reproducible decrease in transaminases in NASH. So bottom line for this, there's some increased risk of all-cause mortality with a dosage greater than 800 units per day. And there is some concern about prostate cancer, even at a dose of 400 units per day. And because of that, the current recommendation is 800 units a day in non-diabetic adults with biopsy-proven NASH. That's the recommendation. I think most of us would say that we're not doing biopsies on everyone. So if you have a FibroScan or lab showing advanced fibrosis, that vitamin E is appropriate. It's probably not something you want to use on somebody that just shows up that has fat in the liver on ultrasound. But currently, just because there were no diabetics in the trial, it's not recommended for diabetics, for people with cirrhosis or cryptogenic cirrhosis. Briefly with pioglitazone, I think most people have some concerns with using it because of weight gain and heart failure risk. You're not going to bypass metformin as your first step of treatment for diabetic patients to go to pioglitazone. But what we know is that if metformin isn't cutting it, or if you need adjunct treatment, there may be some improvement in liver histology in your diabetic patients with NASH. And then finally, statins. This is a big one. These patients should absolutely be on statins. Still, cardiovascular disease is the most common cause of death. Statin therapy may actually improve transaminases, and the vast majority of these patients are going to meet the criteria for cardiovascular risk modification with statin therapy. Just very, very briefly, obetacholic acid, you may have heard about this. There was a push to get the FDA to get fast track approval for obetacholic acid, which is currently used to treat PBC. But in a large multi-center trial, a 72-week study showed that there was improvement in steatohepatitis and fibrosis. Just briefly, in case this is something that comes down the pipeline in the next couple of years, for PBC, it is pretty limited for use by, it's often has to be stopped for pruritus. It can be pretty significant. And then also the last thing we want in these patients is worsening dyslipidemia, and there is some risk of worsening dyslipidemia with obetacholic acid. Okay.
So we do have a question that came in, if you have an opportunity to answer it. So actually, we're getting a couple. So the first one is, they said they lost the internet connection for just a few moments. And so the question is, after getting the NASH panel to exclude other etiologies, when is FibroScan indicated?
So in general, anytime you have someone that has fatty liver or fat on imaging and has some abnormal LFTs with that, the FibroScan is indicated. And I will say personally, I think it's an extremely beneficial tool. Number one, it helps us, risk stratify and know who is at risk to have advanced fibrosis and cirrhosis down the road. And also it can be used as a motivating tool for a lot of patients. If you say, we already see some early changes of fibrosis, that really makes you put a little more emphasis on, you've got to make these lifestyle changes, or you may be looking at cirrhosis down the road. And on the flip side of that, also, sometimes it is helpful once someone has made some diet and lifestyle changes to do a FibroScan again a year later or so, and then to show them, here is an objective number, an objective measure, you did this. And people really sometimes will continue to stay motivated by that.
The next question is probably the last one we'll have time for on air. Is NASH only a pathologic diagnosis, or are there biologic markers for that? So when exactly does it go from NAFLD to NASH?
So really, that's when we see the histologic changes on biopsy. That would be the gold standard to diagnose it, but that's where we're using these stand-in, the FibroScan, specifically the elastography will show us markers of fibrosis. So really, just based on labs alone, you can do the FibroSure, that panel of tests, and it can give you a stand-in for that, but just the basic labs that we have, at our disposal do not make that diagnosis or distinction between the two.
Thank you very much. It was a great presentation, and I know we all enjoyed it.